What's up, my average med students? Welcome to part 2 of our surgery video. This is going to be useful for your shelf review or CK prep. So go ahead and hit the subscribe button and press the bell icon to be notified for all future posts if you already haven't done so. If you like this content, please leave a like and share this with other average med students just like yourself. Let's get going. Clostridial myositis. How do you define this? Clostridial muscle infection. What's the common name for clostridial myositis? Gas gangrene. What's the causative agent for clostridial myositis? C. Perfringens. What are some signs and symptoms of clostridial myositis? Pain, fever, shock, crepitus, foul-smelling brown fluid, and subcutaneous air. What's the treatment for clostridial myositis? IV antibiotics, debridement, tetanus, prophylaxis. Of atelectasis, and what's the etiology and pathogenesis? Inadequate alveolar expansion, 2 out of 2 poor inspiration, or high percent of inspired O2. What are some signs and symptoms of atelectasis? Fever, decreased breath sounds, tachypnea, tachycardia, increased density on chest x-ray. What are some risk factors for atelectasis? Anything that restricts inspiration, oversedation, thoracic surgery, pain on inspiration, COPD, and smoking. What are some prophylactic measures for atelectasis? Pre-op smoking cessation, incentive spirometry, and pain control. Atelectasis treatment. Post-op incentive spirometry, deep breathing, coughing, early ambulation, postural drainage, suctioning, and chest PT. Post-op respiratory failure is defined as respiratory impairment with increased respiration rate, shortness of breath, and dyspnea. Post-op respiratory failure treatment. Supplemental O2, chest PT, suctioning, and you may need to ventilate and intubate them. Post-op respiratory failure initial workup. ABG, chest x-ray, EKG, SAT monitor, O2 SAT monitor, and PE. Post-op respiratory failure indications for intubation and ventilation. Cannot protect airway, they're unconscious, excessive work of breathing, progressive hypoxemia, PaO2 is under 55, and progressive acidosis, RR, respiratory rate is over 35. Post-op respiratory failure, possible causes of post-op pleural effusion. Diaphragmatic inflammation, fluid overload, and pneumonia. Post-op respiratory failure, post-op wheezing, treatment. Albuterol nebulizer. Post-op respiratory failure, danger of supplemental O2 in COPD patient. Hypoxia is what sustains patient's respiratory drive. If there's no hypoxia, then there's no respiratory drive. DVT is more common in which side? The left iliac vein at the aortic bifurcation crosses and compresses. What's the test to evaluate DVT? Duplex ultrasonography. Lab findings in PE. In arterial blood gases, you see decreased PO2 and PCO2, and this is a sign of hyperventilation. PE, diagnostic tests and gold standard. VQ scan, high resolution CT, pulmonary arteriogram is the gold standard. Pulmonary embolus chest x-ray findings. Westermarck sign, which is wedge-shaped of hyperlucency, and opacity with base at pleural edge, 2 out of 2 infarction. Pulmonary embolus, treatment of stable patient. Anticoagulation with heparin and warfarin. Greenfield filter if anticoagulation is contraindicated. Pulmonary embolus indications for Greenfield filter. Anticoagulation contraindication, patient has another PE while on anticoagulation. Pulmonary embolus, treatment of unstable patient. Thrombolytics, catheter suction embolectomy, CT surgeon for Trendelenburg operation. Aspiration pneumonia risk factors. Intubation, impaired consciousness, dysphagia, non-functioning NGT, Trendelenburg precision, intubation with full stomach. Aspiration pneumonia signs and symptoms. Respiratory failure, CP, increased sputum production, fever, cough, MS changes, tachycardia, cyanosis, and infiltrates on chest X-ray. Aspiration pneumonia chest X-ray findings. Early fluffy infiltrates or normal, and late you see pneumonia and ARDS, ARDS. Aspiration pneumonia, which lobes are commonly involved? If the patient's supine, then it's the right upper lobe. If the patient is recumbent position, then it's the right lower lobe. Aspiration pneumonia, what's the most common organisms? If it's community acquired, then it's gram positive, could be mixed. If it's ICU acquired, then it could be gram negative rods. Aspiration pneumonia diagnostic tests. Chest X-ray, sputum gram stain, sputum culture, bronchoalveolar lavage. Aspiration pneumonia treatment. Bronchoscopy, antibiotics, intubation, and ventilation. NG tube. What are some complications? Aspiration pneumonia atelectasis, sinusitis, minor upper GI bleed, epistasis, and pharyngeal irritation. Gastric dilation risk factors. Abdominal surgery, gastric outlet destruction, and splenectomy. Gastric dilation signs and symptoms. Abdominal distension, hiccups, electrolyte abnormalities, and nausea. Gastric dilation treatment. NG tube decompression. What to do with a patient with high NG tube output? Check abdominal x-ray, make sure NG tube is not in the duodenum. You may need to pull back into the stomach. Post-op pancreatitis is defined as pancreatitis with 2 out of 2 manipulation during surgery, low blood flow, which indicates vessel injury, gallstones, hypercalcemia, and medications. Post-op pancreatitis lab tests performed. Amylase and lipase. Post-op pancreatitis initial treatment. NPO, nothing by mouth, aggressive fluid resuscitation, and NGT. Constipation post-op causes. Narcotics and immobility. Constipation treatment. OBR, which is ortho bowel routine, docusate, and dicotyl supplement, and fleet enema. Short bowel syndrome treatment. TPN early and many small meals. Small bowel obstruction, ileus, causes of small bowel obstruction. Adhesions and incarcerated hernia. What are some causes of ileus? laparotomy, hypokalemia, narcotics, intraperitoneal infection. What are some signs of resolving ileus, small bowel obstruction? Flatus, PR, and stool PR. Small bowel obstruction, ileus, order of recovery of bowel function. Small intestine, stomach, and then colon. When can post-op patient be fed through the J-tube? 12 to 24 hours post-op. Small bowel recovers by then. What are some causes of prehepatic jaundice? Hemolysis, resolving hematoma, transfusion reaction, post-cardiopulmonary bypass, blood transfusions, decreased RBC compliance leading to cell rupture due to cell rupture. What are some hepatic causes of jaundice? Drugs, hypotension, hypoxia, sepsis, hepatitis, inflammation from adjacent pneumonia, cirrhosis, right-sided heart failure, abscess, Budd-Chiari syndrome, Gilbert syndrome, Crigler-Najjar, Dubin-Johnson, and fatty infiltrate, and total parenteral nutrition. What are some post-hepatic causes of jaundice? Obstruction, cholangitis, sclerosing cholangitis, cholecystitis, biliary duct injury, pancreatitis, tumors, and biliary stasis. For jaundice, blood tests supporting hemolysis, decrease in hemoglobin and hematocrit, and you'll have increased LDH, reticulocytes, and schistocytes. Blind loop syndrome, what are some causes? Anything that causes stasis. Surgical causes of B12 deficiency in blind loop syndrome. Gastrectomy, because you lose intrinsic factor, and excision because of excision of the terminal ileum, where B12 is absorbed. Post-vagotomy diarrhea cause. Status post-truncal vagotomy, rapid transport of bile salts to colon, leading to osmotic diarrhea. Dumping syndrome is associated with what conditions? Any procedure that bypasses or compromises pylorus function. Dumping syndrome signs and symptoms. Postprandial diaphoresis, tachycardia, abdominal pain and distension, emesis, and increased flatulence, dizziness, and weakness. Dumping syndrome, how do you diagnose it? History, hyperosmolar glucose load with illicit similar symptoms. What's the medical treatment for dumping syndrome? Small, low-fat carb meals, low-carb meals, high in protein. Avoid liquids with meals, and because this slows gastric emptying times. What's a surgical treatment for dumping syndrome? It's a last resort. You convert to Roux-en-Y procedure. In dumping syndrome, reverse jejunal interposition loop. What is this? Segment of the jejunum is cut and reversed. Reverse peristalsis slows intestinal transit. What are the signs and symptoms of DKA? Polyuria, tachypnea, dehydration, confusion, and abdominal pain. DKA associated lab values. Elevated glucose, increased anion gap, hyperkalemia, which 2 out of 2 acidosis, urine ketones, and acidosis. DKA treatment. Insulin, IVF rehydration, and potassium supplementation. Electrolyte to monitor in DKA. Potassium. You watch for hypokalemia. Insulin drives potassium intracellularly. Common cause that must be ruled out in DKA. Infection. And this could be what precipitated the DKA in the first place. Addisonian crisis is defined as acute adrenal insufficiency, 2 out of 2 stressor, like surgery, trauma, or infection. Addisonian crisis number 1 cause. Inadequate cortisol release, usually the result of steroid administration in the past year. Addisonian crisis, signs and symptoms. Volume down can lead to tachycardia. Hypotension can cause hypovolemic shock. Also nausea, vomiting, diarrhea, abdominal pain, and progressive lethargy. Addisonian crisis, classic lab values. Decreased sodium with increased potassium. Addisonian crisis treatment. IV D5-NS, hydrocortisone, and fludrocortisone. SI-ADH, what's the function of ADH? Increased sodium chloride and H2O reabsorption in the kidney, and this increases intravascular volume. What are some causes of SI-ADH? The main cause is lung or CNS trauma or disease. What are SI-ADH associated lab findings? Low sodium, low chloride, low serum osmolality, and increased urine osmolality. SI-ADH treatment. Treat the primary cause, free water restriction. Diabetes insipidus is defined as decreased release of ADH, high intake and output of fluid. Diabetes insipidus, risk factors. Central, head trauma, intracranial disorder. If it's nephrogenic, then you have renal disease, electrolyte disorders, and medications that can cause this. Diabetes insipidus treatment. Vasopressin and IV fluids. Cardiovascular, common causes of dyspnea following central line placement. PTX, pericardial tamponade, carotid puncture, and air embolism. Cardiovascular differential diagnosis of post-op AFib. Fluid overload, PE, MI, pain, atelectasis, pneumonia, digoxin toxicity, hypoxemia, thyrotoxicosis, hypercapnia, acidosis, and electrolyte abnormalities. Differential diagnosis of post-op chest pain. MI, atelectasis, pneumonia, pleurisy, esophageal reflux, PE, musculoskeletal, subphrenic abscess, aortic dissection, could be pneumohemokylothorax, and gastritis. What's a post-op MI presentation? Often no chest pain, new onset congestive heart failure with dysrhythmia, back, neck, and arm pain, tachypnea, and tachycardia. How do you treat post-op MI? Nitrates, aspirin, oxygen, pain control, and beta blockers with heparin. MI treatment of mnemonic. Bemone, beta blockers, morphine, oxygen, aspirin, nitrates. When do post-op MIs occur? 2 to 5 days post-op. Post-op renal failure is defined as urine output less than 25 milliliters per hour with increased creatinine and BUN. Post-op renal failure workup. Electrolytes, BUN, creatinine, urine electrolytes, creatinine, FENA, urine analysis, and renal ultrasound. Lab results for pre-renal or renal. What's the BUN creatinine ratio? For pre-renal, it's going to be greater than 20 to 1. For renal intrinsic, it's going to be less than 20 to 1. Lab value pre-renal or renal, specific urine gravity. For pre-renal, it's going to be greater than 1.02, and because the urine is concentrated, the body is holding on to the fluid. And for renal, it's going to be less than 1.02 because the kidney cannot concentrate. This is the intrinsic renal failure. Lab value for pre-renal or renal, FENA. This is a fraction of excreted sodium. Pre-renal is going to be less than 1%, and renal is going to be greater than 1%. Lab value for pre-renal versus renal for urine sodium. Pre-renal is going to be greater than or less than 20, and for intrinsic it's going to be greater than 40. Post-op renal failure, lab value, pre-renal or renal, urine osmolality. Pre-renal is going to be less than 500, and intrinsic is going to be greater than 350. Indications for dialysis for post-op renal failure. Fluid overload, refractory hyperkalemia, BUN greater than 130, acidosis, uremic complication, encephalopathy, and pericardial effusion. DIC lab findings. Increased fibrin degradation products, elevated PT-PTT, decreased platelets, decreased fibrinogen, schistocytes, and increased D-dimer. Abdominal compartment syndrome is defined as increased intra-abdominal pressure, often post-laparotomy. Abdominal compartment syndrome signs and symptoms. Tight, distended abdomen, decreased urinary output, increased airway pressure, increased intra-abdominal pressure. Abdominal compartment syndrome, how do you measure intra-abdominal pressure? Foley catheter in bladder. What's the normal intra-abdominal pressure? 15. Abdominal pressure requires a treatment. That requires treatment. 25 millimeters per mercury or signs of compromise. Abdominal compartment syndrome treatment. Release the pressure by opening the abdomen. Place clear material over the skin to allow expansion. Urinary retention, what's the diagnosis? Or how do you diagnose it? Physical exam, and you should see a palpable bladder and residual urine volume with Foley. Urinary retention treatment. Foley catheter. Wound hematoma and treatment. Collection of the blood in operative wound. You treat it. If it's acute, that you remove the hemostasis. You remove with hemostasis. If it's subacute, you observe. Heat may help reabsorption. Wound seroma. What's the treatment? Post-op collection of lymph and serum in operative wound treatment. And treatment is needle aspiration. Cholecystitis, referred pain. Right subscapular. Appendicitis, referred pain. Early is going to be periumbilical, umbilical, and then it migrates to testicular rarely. But it should, if it's peritonitis, then it localizes to the right lower quadrant. Diaphragmatic irritation. Shoulder pain. Pancreatitis or cancer, where is the referred pain? Back. Rectal disease, referred pain. Small of back. Nephrolithiasis, referred pain. Testicular or flank. Small bowel, referred pain. Periumbilical, umbilical. Uterine pain, referred pain. Midline small of back. Abdominal pain out of proportion to exam. Rule out mesenteric ischemia first. Hypotension with pulsatile abdominal mass. Ruptured aortic abdominal aneurysm. You go to the OR. Fever, left lower quadrant, plus changed bowel habits. Diverticulitis. Colonic volvulus, what is it? Colon twists around itself and mesentery, causing obstruction, vascular compromise, necrosis, and perforation. Colonic volvulus, most common type. Sigmoid colon. Superior mesenteric artery branches. from proximal to distal, it's middle colic, right colic, and ileocolic. Where from or to is the middle colic artery going? It comes from the superior mesenteric artery and supplies the transverse colon. Right colic artery, where is it coming from and what is it supplying? From the superior mesenteric artery and supplies the right colon. Ileocolic artery, where is it coming from and what is it supplying? The tail end of the superior mesenteric artery is where it comes from and it supplies the cecum and distal ileum. The superior mesenteric artery, where does it come from and what does it supply? It comes from the aorta, supplies the terminal ileum to the transverse colon, and penetrating branches supply small bowel. Inferior mesenteric artery, where does it come from and what does it supply? Comes from the aorta, supplies the descending colon to the sigmoid colon. Inferior mesenteric artery and its branches, where does it come from and what does it supply? Left colic artery, sigmoidal artery, and it supplies the superior hemorrhoidal rectal artery. Superior mesenteric artery relation to the duodenum. Crosses over the third part. Blood supply to rectum. Proximal is superior hemorrhoidal from inferior mesenteric. Middle is middle hemorrhoidal from hypogastric or internal iliac artery. And distal is inferior hemorrhoidal from pudendal artery. Venous drainage of the rectum. Proximal, IMV to splenic portal, middle. Middle is iliac vein to IVC. Distal is iliac vein to IVC. And proximal rectal is portal system. What are colorectal polyps? Tissue that grows into bowel lumen. How do you classify colorectal polyps? By its shape. If it's sessile, that means it's flat. If it's pedunculated, it's on a stalk. What are the polyp types that are inflammatory in colorectal polyps? In Crohn's or UC, but it's not pre-malignant. What are hamartomas? Hamartomatous polyps. Normal tissue in abnormal configuration. What are hyperplastic polyp types? Benign, no malignant potential. Neoplastic subtypes and cancer risk. Villus is the most cancerous, and then you have tubovilus, and then tubular is the least cancerous. Signs and symptoms of colorectal polyps. Bleeding, change in bowel habits, mucus per rectum, electrolyte loss, or asymptomatic. What's the treatment for colorectal polyps? Endoscopic resection. Indication for bowel resection in colorectal polyps. Large sessile villus adenomas. Which colon cancer stage gets adjuvant treatment and what treatment? Dukes C, positive lymph node metastases. They get 5-fluorouracil and leucovorin. Post-op, Duke C colon cancer gets chemo. Which rectal cancer gets adjuvant therapy and what is it? T3 to T4, local invasion through muscularis with negative lymph nodes. They get pre-op radiation plus 5-fluorouracil. What is CI defined as? CO over BSA. What is compliance? Change in volume or change in pressure. What's the normal cardiac output? 4 to 8 liters per minute. What's the normal cardiac index? 2.5 to 4 liters per minute. Ways to increase cardiac output. MR pair is a mnemonic, and mechanical assist would be IABP, ventricular assist device, or rate control. And then also you can do preload increase, afterload decrease, inotropes to increase contractility, and rhythm control, keep the NL sinus. When does coronary flow happen? During diastole. The three major coronary arteries, what are they? LAD, circumflex, and right coronary. Patients who get silent MIs. Diabetics, because the autonomic dysfunction, and they have no pain. What's the indication for cabbage? Left main disease, 3-vessel disease, unstable disabling angina, post-infarct angina, coronary artery rupture, dissection, thrombosis after percutaneous intervention. Cabbage, most commonly used vessels for graft. IMAs, saphenous vein. IMA 10-year patency is 95%, saphenous 10-year patency is 70%, and other stuff is radial artery and inferior epigastric. Post-op meds for cabbage patients. Aspirin and beta blocker. Post-pericardiotomy syndrome is defined as pericarditis after pericardiotomy. Post-pericardiotomy syndrome, when does it occur? About 3 weeks post-op. Post-pericardiotomy syndrome, signs and symptoms. Fever, chest pain, atrial fibrillation, malaise, friction rub, pericardial or pleural effusion. Post-pericardial syndrome treatment. NSAIDs plus or minus steroids. Post-pericardiotomy syndrome, pericarditis after MI. What's the name? Dressler syndrome. What's the physiology of tamponade? Decreased cardiac output, increased heart rate, hypotension, increased CVP wedge pressure. Cardiopulmonary bypass complications. Trauma to formed blood elements, pancreatitis, 2 out of 2, low flow, heparin rebound, CVA, failure to wean, and MI. Cardiopulmonary bypass options to treat post-op cabbage bleeding. Protamine, increased PEEP, FFP, platelets, aminocaproic acid. Heparin rebound, what does that mean after cabbage? Increased anticoagulation after CPB, increased peripheral blood flow, returns, remobilizes heparin that was stored in underperfused tissue during operation. Cardiopulmonary bypass, how do you lower SVR after CPB? Warm the patient, give nitroprusside and dobutamine. Cardiopulmonary bypass, options to help wean. Inotropes and VAD, ventricular assist device. What is a VAD, ventricular assist device? Cardiopulmonary bypass, workup of post-op patients with AFib. Chest x-ray to rule out pneumothorax, arterial blood gas to rule out acidosis, labs to rule out electrolyte abnormalities, and EKG to rule out ischemia. Aortic stenosis, what are the causes? Calcification of the valve, bicuspid aortic valve, rheumatic fever, damaged valve, or just being old, just old age. Aortic stenosis symptoms: angina, syncope, and congestive heart failure. Aortic stenosis signs: murmur, you hear a crescendo decrescendo systolic at the aortic position, and sometimes left ventricular heave or lift 2/2 left ventricular hypertrophy. Aortic stenosis workup. Chest x-ray, EKG, echo, and cardiac catheterization. Aortic stenosis surgical treatment. Valve replacement. Aortic stenosis indications for surgery. Area less than 0.75 centimeters squared. Gradient greater than 50 millimeters per mercury. And symptomatic. Aortic stenosis option in poor surgical candidates. PCT balloon valvuloplasty. Aortic stenosis murmur volume correlation with outcome. Louder is better. Left ventricular function is preserved, that means. Aortic insufficiency. What are the top three causes? Bacterial endocarditis, could be Staph aureus or Strep viridans. Rheumatic fever, annular ectasia from collagen, vascular disease, especially Marfan's. Aortic insufficiency, predisposing conditions. Bicuspid aorta and connective tissue disease. Aortic insufficiency symptoms. Dilated left ventricle over the palpitations, dysrhythmias, failing left ventricle, leading to orthopnea and dyspnea. Mitral stenosis signs. Murmur, decrescendo diastolic, dilated left atrium, leading to irregular pulse, 2/2 AFib, stroke, 2/2 emboli from the left atrium in AFib. Mitral stenosis diagnostic tests. Echo and catheterization. Mitral stenosis indication for intervention. Symptoms, if they're symptomatic, pulmonary hypertension and mitral valve area less than 1 centimeters squared over meter, and recurrent thromboembolism. Aortic insufficiency signs. Murmur, blowing decrescendo diastolic at the left sternal border, Austin Flint murmur. It means you hear reverb of regurgitant flow, and increased pulse pressure. This is called the water hammer pulse. Aortic insufficiency, what is Corrigan's pulse? Low diastolic pulse pressure and wide pulse pressure. Aortic insufficiency, diagnostic tests. Chest x-ray, increased heart size, echo, and catheterization. Aortic insufficiency treatment. Replace the valve. Aortic insufficiency indications for surgery. What are the top three? Symptoms, left ventricular dilation and decreasing function and acute onset. Mitral stenosis, most common cause. Rheumatic fever. Mitral stenosis, top 4 symptoms. Increased left atrial pressure, causing dyspnea, hemoptysis, hoarseness due to the dilated left atrium impinging on the right recurrent laryngeal nerve, and palpitations due to AFib. Mitral stenosis treatments. Open commissurotomy, balloon valvuloplasty, and valve replacement. Mitral stenosis medical therapy for mild symptoms. Diuretics. Mitral regurgitation causes. Top 4. Mitral valve prolapse, rheumatic fever, post-MI from papillary muscle rupture, and ruptured chordae tendineae. Mitral regurg, most common causes. Rheumatic fever over ruptured chordae tendineae, papillary muscle rupture. Mitral regurg symptoms. Dyspnea, palpitations, and fatigue. Mitral regurg signs. Holosystolic blowing murmur at the apex. Mitral regurg indications for treatment. Symptoms, left atrial pressure or left atrium is greater than 45 millimeters, and end diastolic dimension dilation. Mitral regurgitation treatment. MVR and annuloplasty. Artificial valves, synthetic versus tissue. What's the difference? Tissue valves don't last, but don't clot. Give to old people. Mechanical valves clot and they last a long time, so you give those to young people. Ross procedure, what is this? Pulmonary valve for aortic valve autograft. Infectious endocarditis, predisposing conditions. Pre-existing valve lesion, procedures, IV drug use that lead to bacteremia. Infectious endocarditis, most common bugs. Viridans, Staph aureus, and Staph epidermidis. Infectious endocarditis, common bug with abnormal valves. Strep viridans. Infectious endocarditis, common bug with IVDA. Staph aureus. Infectious endocarditis, common bug with prosthetic valve. Staph epidermidis. Infectious endocarditis signs. Murmur, petechiae, splinter hemorrhage, Roth spots on the retina, ossular nodes which are painful, and Janeway lesions. Infectious endocarditis, ossular nodes versus Janeway lesions. Both on the palms and soles, ossular nodes are raised and painful, and Janeway lesions are flat and painless. Ossular, you can remember it as ouch. Infectious endocarditis diagnosis. Echo, transesophageal echocardiogram, serial blood CX. Cultures. Infectious endocarditis treatment. IV antibiotics. Congenital heart disease, VSD, what's the most common location? Membranous portion of the septum, about 80% of the time. Pulmonary vascular obstructive disease, VSD. Pulmonary artery hyperplasia, 2 out of 2 increased pulmonary pressure, 2 out of 2 left to right shunt. What is Eisenmenger syndrome? Irreversible pulmonary hypertension, causing, and then you have a reversal of shunt, and now it becomes right to left. So it goes from left to right to right to left. Eisenmenger syndrome treatment. Heart-lung transplant, only otherwise fatal if you don't transplant. Factors that keep PDA open. Hypoxia, increased prostaglandins, and prematurity. Congenital heart disease, what are the symptoms of PDA? Often none, poor feeding, respiratory distress, congestive heart failure, and respiratory infection. What are some signs of PDA? Acyanotic continuous machine murmur. What are some diagnostic tests for PDA? Echo and catheter. What is the treatment for PDA? Medical, you would give endomethacin to close it, and surgical, you would ligate and cath embolization at 6 months to 2 years. Tetralogy of Fallot, what are the 4 parts? Pulmonary stenosis, overriding aorta, right ventricular hypertrophy, and VSD. Tetralogy of Fallot symptoms. Hypoxic spells improved with squatting. Tetralogy of Fallot signs. Cyanosis, clubbing, systolic ejection murmur at the 3rd intercostal space. Tetralogy of Fallot diagnosis. Chest X-ray, small boot-shaped heart with decreased pulmonary blood flow, and echo. Congenital heart disease, what is IHSS? Idiopathic hypertrophic subaortic stenosis. How does IHSS present? Sudden death, 2 out of 2 dysrhythmia, syncope with congestive heart failure. Coarctation of aorta, what's the usual location? Near the ductus ligamentum arteriosum. Coarctation of aorta, what are the three types? Preductal, juxtaductal, and postductal. Coarctation of aorta, which one is the fatal type? Preductal, will kill in infancy. Coarctation of aorta, major route of collateral flow. Subclavian artery to IMA to intercostals to the descending aorta. Coarctation of aorta, risk factors. Turner syndrome and being female. Coarctation of aorta, symptoms. Upper body hypertension, headache, epistaxis, lower body hypotension, lower extremity fatigue, and claudication. Congenital heart disease, coarctation of aorta, signs. Decreased lower extremity pressures, murmurs, systolic from coarctation, and continuous from collateral circulations. Coarctation of aorta, diagnostic tests. Chest x-ray, 3 signs. Aortic notch, coarctation, aortic knob, coarctation, dilated post-stenotic aorta, rib notching, echo, and cardiac cath of defects. Coarctation of aorta, treatment. Surgery. You may do endovascular in adults. Coarctation of aorta, indications for surgery. Symptomatic patient, asymptomatic, older than 3 to 4 years old. Transposition of the great arteries. How does it present? Cyanosis and congestive heart failure in first few days of life. What are the diagnostic tests for TGA? Chest x-ray, you see an egg-shaped heart contour on cardiac cath. TGA treatment. Arterial switch operation. What is Epstein's anomaly? Tricuspid is too low in the right ventricle, large right atrium, and small right ventricle. Tricuspid regurg and decreased right ventricular output. Vascular rings diagnosis. Barium swallow and MRI. 5 causes of cyanotic heart disease. Tetralogy of flow, truncus arteriosus, tricuspid atresia, transposition of the great arteries, total anomalous pulmonary venous return, TAPVR. What is the most common benign cardiac tumor? Myxoma. What's the most common location of a myxoma in the heart? Left atrium, pedunculated morphology. What's the most common malignant tumor in kids for heart? Rhabdomyosarcoma. Thoracic aortic aneurysm causes. Atherosclerosis, connective tissue disease. Thoracic aortic aneurysm, how do you diagnose? And what are some extra tests you can do? Routine chest x-ray, plus CT, MRI, and aortic aortography. Thoracic aortic aneurysm, indications for surgical treatment. Greater than 6 centimeters in diameter, greater than 2 times the normal aorta diameter, symptoms, rapid size increase, and rupture. Thoracic aortic aneurysm treatment. Replace with graft. Thoracic aortic aneurysm, best way to follow an aneurysm? Serial sonograms. Number 1 cause of mortality in post-op patients in thoracic aortic aneurysms. Early is going to be MI, and late is going to be renal failure. Bloody bowel movements immediately post-op in a patient with thoracic aortic aneurysm. Sigmoid ischemia, workup with gentle endoscopy, treat with sigmoid resection. Bloody bowel movements, distant post-op in patients with thoracic aortic aneurysm. aortoenteric fistula workup with angiogram, CT, endoscopy, treat with emergency surgery, bypass and remove infected graft. Thoracic aortic aneurysm, dreaded complications. Paraplegia, anterior spinal syndrome. Aortic dissection classification systems. DeBakey 1 is ascending and descending. 2 is ascending only. 3 is descending only. Stanford type A is any ascending, and Stanford type B is descending only. Aortic dissection etiologies. Hypertension is the number one cause, and then you also have Marfan's, bicuspid aortic valve, coarctation of the aorta, cystic medial necrosis, and proximal aortic aneurysm. Aortic dissection signs and symptoms. Abrupt, severe, ripping chest pain, radiation to the back. Aortic dissection 3 sequelae. Cardiac tamponade, aortic insufficiency, aortic arterial branch occlusions, and shearing. Aortic dissection diagnosis. Chest X-ray followed by a transesophageal echocardiogram, CTA, with aortography. Aortic dissection treatment and why. If the ascending aorta is involved, surgical. If the descending only, then you give medical BP control. Ascending due to the aortic insufficiency and cerebral coronary circulation compromise, and tamponade and rupture. That's why you have to immediately do surgery. What's the cause of MI in a patient with aortic dissection? Dissection can lead to coronary involvement or of the underlying LAD. Or underlying LAD, sorry. EKG buzzwords for AFib. Irregularly irregular. EKG buzzwords for PVC. Premature ventricular complex with wide QRS. EKG buzzwords for ventricular aneurysm. ST elevation. EKG buzzwords for ischemia. ST elevation or depression with inverted T waves. EKG buzzwords for an old infarction. Q waves. EKG buzzwords for pericarditis. ST elevation in all leads. EKG buzzwords in right bundle branch block. Wide QRS, rapid years, RR in V1 and V2. EKG buzzwords in left bundle branch block. Wide QRS, rapid years, RR in V5 to V6. Wolff-Parkinson-White syndrome, what are the EKG buzzwords? Delta wave, slurred upswing QRS. EKG buzzword for first degree AV block. Prolonged PR interval, 0.2 seconds. EKG buzzwords for Wenckebach. Second degree block with progressive PR delay before dropping a beat. EKG buzzwords for third degree heart block. Complete AV dissociation, random P and QRS.
Alright guys, that about wraps it up. Thank you for watching, and if you liked this video, please share. Today we completed about
265 cards.
It's not bad. And stay tuned for part
3 of surgery videos, and there's a lot more to come.
You don't want to miss out, and I really hope this is helping you. If you have any comments or suggestions or even any corrections to any wrong information that I may have presented, please go ahead and leave a comment down in the comment section below. And have a great day, guys. Bye-bye.